What the Study Says.
Welcome back to What the Study Says. Imagine for a moment you're having a lively conversation, maybe telling a story, when suddenly the words you need just vanish. They're right there in your mind, but your mouth, it just can't form them. Or someone asks you a simple question, and their words sound like, well, like a foreign tongue, even though you know it's English. It's not memory loss, not exactly confusion. It's a profound disconnect, a breakdown in the very fabric of how we communicate and connect. Today, we're embarking on a deep dive into that incredibly challenging condition.
Indeed. And it's a reality for far more people than most of us realize. We're talking hundreds of thousands impacted each year, often after something sudden, a life-altering event. The ability to use language is so fundamental. And when it's lost, the world shifts dramatically. I'm Dr. May.
And I'm Dr. Kai. Today, our focus is aphasia, a condition that can strip away the ability to produce or understand language. We'll explore exactly what it is, how doctors pinpoint its presence, the science underpinning recovery, and the promising, sometimes surprising, frontiers of treatment.
Okay, let's really unpack this. Aphasia. It isn't just a minor communication hiccup, forgetting a word here or there. It's a profound impairment, a loss of the ability to comprehend or formulate language, whether that's spoken, written,
Or even sign language.
Right, and the impact, it extends far beyond just talking, doesn't it?
Oh, absolutely. What's particularly striking from the research is just how devastating this condition can be, for the individual and for their loved ones, too. Our studies consistently highlight it as one of the most feared consequences of brain injury, especially following a stroke. I can imagine being unable to express basic needs or join a conversation.
Exactly. Or even read a simple sign. It directly affects, everything. Employment status, the ability to maintain social networks, and it significantly increases stress, sometimes leading to depression for both patients and their caregivers.
That makes sense.
When communication breaks down, it truly affects every facet of life. It can even limit a patient's ability to participate effectively in other crucial rehab efforts.
Like physical therapy, because they can't understand instructions.
Precisely. It creates huge barriers.
So what triggers this major disruption to our language abilities?
Well, the research is pretty clear. The most common culprit is cerebrovascular disease.
Which, for our listeners, essentially means conditions affecting the brain's blood vessels.
Exactly. And specifically, an ischemic stroke, where a blood clot blocks blood flow to part of the brain that's a very frequent cause. In fact, aphasia complicates somewhere between, say, 15 to 38% of all ischemic strokes. That's a significant number.
Wow, it is.
But it's not solely strokes. Other structural brain issues can do it too. Things like severe infections, traumatic brain injuries, brain tumors, and even certain insidious neurodegenerative diseases can also lead to aphasia.
So that raises a really important question then. Are all aphasias the same?
No, not at all. That's a key point. The literature details many different types. They're meticulously categorized by how they affect specific language abilities.
Okay.
For example, some individuals struggle intensely to produce speech. They speak slowly, with great effort, but they can usually understand most of what's said to them.
Okay.
This classic presentation is known as Broca's aphasia, often called expressive aphasia.
Expressive. Got it.
Then you have patients who can produce speech quite fluently, sometimes even rapidly, but it's often filled with, meaningless words, or what we sometimes call word salad.
Word salad.
Yes, and they struggle significantly to understand language themselves. That's Wernicke's aphasia or receptive aphasia.
So they can talk, but it might not make sense, and they don't understand you either. That sounds incredibly isolating.
Precisely. It's a profound disconnect, and the spectrum continues. There's global aphasia, which is the most severe form. A person can neither speak nor understand written or spoken language effectively.
That's devastating.
It is. And then on the other end, you have conditions like anomic aphasia. Here, the primary difficulty is naming specific objects.
So they know what it is, but can't find the word.
Exactly. They might be able to describe what the object does or what it's used for, but the specific noun just won't come. Understanding these distinctions is really crucial. They give us clues about the underlying brain region affected and help guide our approach to therapy.
All right, so if aphasia messes with our words, where exactly in our amazing brains does language live? This is where it gets incredibly intricate. Really fascinating stuff.
It really is. It's not a single isolated spot. Think of it more like a large, complex network. And it's predominantly located in one hemisphere.
The left, usually.
Indeed. For the vast majority of people, over 95% of right-handed individuals, language functions are left hemisphere dominant. And even among many left-handed individuals, it's still predominantly on the left.
Interesting.
Within this specialized hemisphere, we've historically identified those classic language centers, like Broca's area, which is crucial for the motor programming and production of speech, basically forming words and sentences.
Right.
And then there's Wernicke's area, vital for comprehending speech and assigning meaning to words. That's how we understand what others are saying. But, the insights from modern neuroimaging, they reveal it's far more distributed than just those two famous spots.
Right. The research shows our brains are truly orchestral in how they function. It's not just soloists. Other regions contribute significantly too, like the insula, involved in articulation.
Exactly, coordinating the movements for speech. And vast regions across the frontal and temporal lobes play roles in processing complex sentences, while extensive areas of the temporal, occipital, and parietal cortex are involved in storing and retrieving word knowledge and meaning. Your internal dictionary, basically.
Our mental encyclopedia. And get this, something I found really surprising in the recent studies.
What's that?
Increasing evidence that even cerebellar lesions damage to the cerebellum, which we usually link to motor control and balance, can result in subtle but significant linguistic deficits, including grammatical problems.
That is fascinating. It really highlights the brain's interconnectedness. Our understanding of language's reach within it is constantly expanding.
It's a powerful point, and it helps explain why aphasia can present in such varied ways.
It does. The onset, for instance, can be acute or subacute, often due to sudden structural damage from events like a stroke or maybe a rapidly growing tumor. We even see transient episodes of aphasia sometimes, ones that might resolve quickly.
Like from migraines or seizures.
Exactly, almost like a temporary electrical short circuit.
Yep.
Then there are the progressive forms, like primary progressive aphasia or PPA.
Right.
This isn't caused by a sudden event. It's part of broader neurodegenerative diseases. PPA has an insidious onset, meaning it starts subtly and slowly worsens over time. It gradually erodes language abilities, often without affecting other cognitive functions initially.
So it creeps up slowly.
Yes. And understanding this difference in onset, sudden versus gradual, is crucial for diagnosis and for counseling patients about what to expect.
So if someone comes in with language difficulties, how do doctors actually pinpoint what's happening? And maybe more importantly, figure out what type of aphasia it might be. It sounds like it requires way more than just a quick chat.
Oh, absolutely. It's an incredibly detailed and systematic clinical assessment. A comprehensive evaluation. It involves a multifaceted approach. Doctors, often working closely with speech-language pathologists, evaluate various aspects of language.
Like what specifically?
Well, we look at a person's fluency in speech. Is it smooth or halting and effortful? We analyze the content of their language, carefully noting things like paraphasic errors.
Where they substitute words, like saying table for chair.
Exactly. Or using neologisms, entirely new, made-up words.
Okay.
These specific errors are really key indicators. They help us localize the damage and understand which parts of the language network are most affected.
Those sound like very specific clues. And the tests themselves must be quite revealing.
Indeed. We test their ability to repeat phrases that assesses the connection between comprehension and production areas. We'll ask them to name objects, to evaluate their lexical retrieval, their word finding, and critically we assess their comprehension, both spoken and written language. Do they understand instructions, questions, a paragraph they read?
Can you give an example of a specific test?
Sure. From the research, you see examples like asking patients to repeat phonetically challenging phrases, things like hopping hippopotamus or Methodist Episcopal.
Yeah, those are tricky.
They're not just tongue twisters. They test phonetic complexity and the motor planning needed for speech. For comprehension, we might give commands like, touch your right ear with your left thumb. That tests understanding of spatial relationships, body parts.
Okay, I see.
Or complex logical questions like, if a lion was killed by a tiger, which one is still alive?
Ah, that really forces you to process the meaning carefully.
Exactly. It truly breaks down how the brain processes language, going beyond just what you say to how you say it and if what's said actually makes sense to you.
That's a fascinating way to unravel the brain's language processing. But even with that detailed assessment, are there common pitfalls? Other conditions that might sort of mimic aphasia and make diagnosis tricky?
That's a vital question. These detailed assessments are invaluable because they help classify the aphasia into those specific syndromes we mentioned, Broca's, Wernicke's, global, and so on, and these often correlate with the location and extent of the brain damage. However, it's also absolutely crucial to distinguish true aphasia from other conditions, things that might look similar on the surface but have different underlying causes and, importantly, different treatments.
Like what, for example?
Well, severe depression can make a person withdrawn, reluctant to speak. Delirium can cause disorganized thought and speech. Even certain aspects of schizophrenia can present with language disturbances that might be confused with aphasia if you're not careful.
So a careful, nuanced exam is key.
Absolutely key to avoid misdiagnosis, especially since many chronic aphasia patients can also develop depression, which further complicates their presentation.
So the diagnostic journey starts with those detailed language assessments, but I imagine getting a picture of the physical brain is also critical early on. Is a structural brain scan usually the first port of call?
Precisely. After the initial clinical evaluation, a structural brain scan, typically an MRI, is pretty standard. We need to look for the underlying cause. Is it a stroke that's just occurred? Is there a tumor growing? Or some other structural pathology causing the problem?
That information must guide treatment significantly.
It does. And if the aphasia is episodic, coming and going, then we might look for other things.
Like seizures?
Yes, using an EEG, maybe. Or investigate transient ischemic attacks, those mini strokes, with cerebrovascular imaging. It's really a combination of understanding the functional deficits, what the person can and can't do with language, and seeing the physical changes in the brain.
This all sounds incredibly challenging, especially considering the profound impact on daily life you mentioned. But for those affected, the really big question is always, will I get better?
Right.
What do the studies actually say about prognosis, about the likelihood of recovery?
Well, there's good news here. The vast majority of patients with post-stroke aphasia do improve to some extent. The brain is remarkably adaptable.
That's encouraging.
It is. What's fascinating, though, is the timing. Most of this spontaneous improvement, the recovery that happens kind of on its own, occurs within the first few months. The rate of improvement often slows down and tends to plateau after about a year.
A year, okay.
And interestingly, those with milder aphasia right at the onset, they tend to have the best prognosis for a fuller recovery.
Makes sense. Are there other factors?
Yes. Other factors can influence outcomes, too. Things like younger age, a higher educational level before the injury, even the type of stroke, hemorrhagic strokes involving bleeding, sometimes show slightly different recovery patterns than ischemic ones. So yes, there's always hope, and often significant improvement is possible.
While that spontaneous recovery is a factor, what really excites researchers, and patients I'm sure, are the active steps. What can actually be done? Is it just a waiting game, or are there active treatments?
Definitely not a waiting game. While the brain does amazing things on its own, our sources consistently emphasize that the underlying cause of the aphasia should always be treated specifically, if possible.
Like removing a tumor.
Exactly. Or controlling epileptic seizures with medication. That's step one. But beyond that, speech and language therapy is really the gold standard of care. It's not necessarily about restoring old pathways perfectly, but about harnessing the brain's remarkable ability to reroute, to create entirely new connections, sometimes utilizing areas we previously thought were less involved in language.
That neuroplasticity concept.
Precisely. That's a major focus of modern therapy. The research, however, offers a bit of a nuanced picture regarding specific techniques. While there's, let's say, weak evidence to definitively recommend one specific technique over all others, what does seem to matter significantly is the intensity and the number of sessions.
So consistency and effort are key.
It really seems so. More than the exact method itself, it's about consistent, targeted practice.
So it's about putting in the work.
Yeah.
And that emphasis on intensity is interesting. Does that mean we're also seeing new ways of delivering therapy, maybe involving technology?
Absolutely. And here's where it gets really interesting as we look towards the future of care. Newer techniques are indeed showing considerable promise. We're seeing the rise of computer-assisted therapy that can provide highly repetitive, individualized exercises, which is great for practice. Right. Then there's something called constraint-induced aphasia therapy, or CI8 for short.
CI8. Yeah, okay.
This is a high-intensity approach. And what it does is it restricts the use of nonverbal communication gestures, pointing, that kind of thing. It forces the patient to rely only on verbal output.
Why do that? It sounds tough.
It can be, but the idea is to overcome what's called learn non-use, where patients might start avoiding speaking because it's difficult and rely more on gestures. By constraining those alternatives, the therapy encourages and strengthens the damaged language pathways.
I see. Forcing the system to work.
In a way, yes. And increasingly, we're seeing the use of downloadable apps on smartphones and tablets.
Oh, yeah?
Yeah, offering accessible, often engaging ways for patients to practice at home, extending the therapy reach. These digital tools are showing real promise for helping patients recover or find alternative, more efficient ways to communicate.
That's fascinating how technology is stepping in. But what about medications?
Yeah.
Is there any hope there?
Yeah.
Can we just take a pill to magically get our words back?
Unfortunately, that's not quite the reality yet, though it's definitely an active area of research. Our sources state there's currently insufficient evidence to recommend pharmacologic interventions for unequivocal long-term benefit across the board for aphasia itself. Clinical trials have explored a range of medications, things like bromocriptine, which affects dopamine, amphetamine, a stimulant, paracetam, a kind of cognitive enhancer, even acetylcholinesterase inhibitors like donepezil, which are used in Alzheimer's disease.
So lots of attempts.
Lots of attempts, but definitive, consistent long-term results that universally improve aphasia just haven't been found yet.
So it's not a silver bullet situation.
Yeah.
But you mentioned one specific study earlier that sounded a bit hopeful.
Yes, that's an important distinction to make. While the general consensus remains cautious, there was one specific study that showed memantine, another drug often used in Alzheimer's, an NMDA receptor antagonist, when it was combined with that intensive CIAT therapy.
Okay.
It demonstrated sustained benefits for patients with chronic post-stroke aphasia.
Sustained benefits.
Yeah.
That is hopeful.
It is. It suggests that while standalone drug treatments might not be enough, perhaps combination therapies pairing medication with intensive behavioral therapy might unlock new potential down the road. And, critically, we absolutely have to manage co-occurring conditions, especially depression.
Right. You mentioned that earlier.
Yes, because depression can significantly impair a patient's motivation and their ability to really engage in therapy, which obviously impedes overall recovery. Addressing mental health is vital.
And beyond traditional medication, there are even more cutting-edge approaches being studied. Things that aim to directly influence brain activity itself, like brain stimulation.
Precisely. Non-invasive brain stimulation techniques. Things like transcranial magnetic stimulation, TMS, and transcranial direct current stimulation, or TDCS. These hold considerable promise, though it's important to stress they are still largely experimental, not yet standard clinical practice for aphasia.
How they work, basically.
Well, these methods aim to modulate brain activity. They can either excite or inhibit specific brain regions non-invasively from outside the skull. The goal is potentially enhancing that neuroplasticity we talked about, guiding language recovery.
So you might stimulate underperforming language areas.
Exactly. Or potentially inhibit other areas that might be compensating, but perhaps less efficiently. The idea is to guide the brain towards more optimal language processing routes. Small studies have indeed shown some benefits, particularly when these techniques are combined with intensive speech therapy.
So again, combination seems key.
It often is in brain recovery. These studies are paving the way for larger, more definitive future research. It's really a glimpse into what might be possible for enhancing recovery in the years to come.
So what does this all mean for you, our listener? Aphasia. It's clearly a complex and often devastating condition. It impacts a person's fundamental ability to communicate, to connect with the world around them. It's most commonly caused by stroke, but as we heard, also by other brain injuries and those neurodegenerative diseases like primary progressive aphasia.
And while the journey through aphasia is undeniably challenging, the research clearly indicates that most patients do experience some degree of improvement, especially with intensive, consistent speech and language therapy. The ongoing advancements in technology and pharmacology, alongside those cutting-edge brain stimulation techniques, they offer a genuinely hopeful future. A future for enhanced recovery and significantly improved quality of life, understanding the brain's incredible capacity for language, its intricate network, and its remarkable resilience and ability to adapt. It's just a constant reminder of its complexity and of our evolving medical knowledge.
It truly is. The resilience of the human spirit facing such profound communication challenges, coupled with that relentless pursuit of scientific understanding, it makes the journey through aphasia a powerful testament to human connection. So as we wrap up this deep dive, here's maybe a provocative thought for you to ponder. How would your own definition of self change if you suddenly couldn't articulate your thoughts or understand the words of others? What new forms of connection or communication might you discover or even invent if your primary language pathways were compromised?
Thank you for joining us on this deep dive into aphasia. We really hope this exploration has given you a clearer, maybe more nuanced understanding of this challenging yet truly fascinating condition.
If you found this discussion valuable, please do hit that subscribe button and share what the study says with others who are curious about the latest in medical science. Until next time, stay curious.